Welcome to the Virginia Mason Institute quarterly webinar series, Building Lean Leaders. Our presentation today is What Does It Take to Lead a Lean Culture Change? The Executive's Role. My name is Susanna Garitano, and as an Institute team member, I'm proud to introduce our presenter today, Diane Miller. Just give me 1 second. Having trouble. There we go. Okay. Diane Miller is a vice president at Virginia Mason, the executive director of Virginia Mason Institute, and an executive sensei for various clients around the world. As a key member of Virginia Mason's executive team, she helped design the infrastructure to support the organization's adoption of the Virginia Mason production system as its management method since Virginia Mason began its lean journey in 2001. The Virginia Mason production system is the adaptation of the lean principles and practices of the Toyota production system to healthcare. Today, Diane continues as an executive with Virginia Mason, as well as coaches many other executive teams who desire to adopt a similar management system using lean. As with all Virginia Mason executives, she is certified in the Virginia Mason production system. Diane and I encourage you to ask questions throughout the session using the GoToWebinar chat or question tool. We will adjust questions during our live Q&A session following the presentation. Today's session is being recorded and will be posted on our website at virginiamasoninstitute.org. In addition, each of you will receive a link to the recording and the Q&A document via email following the session. Thank you for attending. I will now hand it over to Diane.
Hello everyone, it's so good to be with you today in this important topic, and I think it's one I certainly, and I and the other executives at Virginia Mason often get asked. And while I'm speaking primarily about the executive's role in leading culture change, and we make that point explicit, I believe that the culture change lies with the CEO and their team, and it requires everyone to be engaged. That said, I don't want you to believe that once a culture is in place, that an executive, a CEO, can't change and totally disrupt the culture, and that's why we say it flows from the CEO. So I want to share with you some of the specific actions that we as executives within Virginia Mason have done to influence our culture, from what it was in 2000 to what it is today in 2016. These actions will include how we've engaged all 5,500 staff and growing to be safety inspectors and to understand our work is all about putting the patient first in that work and guides all of our decisions. So we're going to be talking about what's the executive's role, the actions that are necessary to align our leaders and our staff for sustained culture change, and what are the requirements of engaging all staff in changing the culture. It can be argued that the only thing of real importance that leaders do is to create and manage culture, that the unique talent of leaders is their ability to understand and work with cultures, stated by Edgar Schein. Our work begins really with describing what we seek and what we aspire to. And for Virginia Mason, many of you who've heard other presentations by us know that it begins with our strategic plan and this iconic depiction of that plan. And this vision is everywhere, and it's not just a vision that's created at the beginning and then put on the shelf, but something that's a living document for us and we reference on a regular basis. So wondering, in your own organizations, one place to begin is, do you have the kind of clarity about what you aspire to be and how you can align all of the work along this strategic plan? So we begin with our vision and making sure that everyone in the organization understands that vision. Continuing to define not just what we want to be, but really being humble and honest about where we are today and what we look to realize as time goes by in changing our culture. And you'll see on the left side of this graphic that we began our journey in 2000 with provider first, waiting is good, errors are to be expected in healthcare, and diffuse accountability. And of course, we need to add more resources to have improved quality. But what we realize, or what we aspire to be, is that the patient really is at the center of all our decisions and how we operate on a daily basis. That waiting is bad, and that we can have defect-free medicine, rigorous accountability. And we say, and much to worries of many people, that there are no new resources, that we can find solutions within the resources that we have. So have you defined what you want your culture to look like, feel like, and sound like? And I think that's a very important first step. So here's an example, excuse me, of a transformation journey and where you might begin and where you aspire to be. And starts with our quality and safety, that when we began, our quality department really owned quality goals, and we aligned quality targets with regulatory mandates, and I think many organizations are there. But as we progress in a new culture, we understand the importance of our operational leaders to own quality and safety results. And our vision includes the goal of eliminating defects. The number of safety concerns reported should be increasing, not the harm, but the reporting, so that we know how we can address those errors. And finally, as we progress to a new culture, we realize that each individual in our organization is responsible for quality and safety. We actively seek and publicize and eliminate defects. Safety reporting is considered an important responsibility for everyone. And so our processes and our policies and our procedures all are aligned with how do we achieve everyone seeing themselves as a safety inspector. So the culture of safety and the beliefs are driving that culture. And so we need to dig deeper into what are our beliefs that are driving the cultural behaviors of our organization. So at Virginia Mason, these are our beliefs, and we clearly state them and talk with our staff and orient our staff to these. The patient is first, as I've mentioned, 0 defects. Respect for people, that each person is treated with dignity and respect by everyone they encounter. People are given the training and tools they need to develop their full potential, and each person is recognized and appreciated for the work they do. That there's transparency, and that there's a learning organization, which I'll speak to in a moment. Well, what is good enough? What is 0 defects? Why is that so important? And it's really about imagining 99.9% quality at Virginia Mason would still mean that we had this number of defects. So we help our staff understand that the only acceptable defect rate is 0. We seek 0 defects as a fundamental belief. It includes a recognition that there's a cost to the customer, but those in our system as well, and that none are acceptable. Here are some examples of how we reduce the cost to humans and the cost to the organization. We're particularly proud of our top hospital of the decade for 10 years consecutively improving in quality and safety. The leader's role is to set targets beyond our comfort level. Status quo is not acceptable. To not be satisfied and push our boundaries, knowing that the method deeply allows us to have the courage to set those, is important. The training that all of our executives and sponsors of improvement work know that they can understand how bold we can be in reducing waste in our processes. Staff will speak up. A part of our culture is constantly improving the percentage of staff, when we survey them, believe that they can speak up regarding any concern that they might have. And we measure this. And of course, looking at this, it's a very high percentage of people in our organization feel comfortable speaking up when they see a safety concern. But really, is that good enough, even though it's quite high for the average? What is keeping 20% of our population, our staff, from speaking up? That's an important thing for us to understand. As we began to study this, we realized that staff had concerns about retribution, that they weren't comfortable, that the hierarchy in healthcare it still exists among the staff. But why is the this important? Why is respect important? Because it's about personal engagement. Am I willing to step in and make known concerns of the organization? Having personal engagement then leads to teamwork and communication, and we know many errors occur related to communication in healthcare. And of course that leads to reliability when we have good teamwork and communication. So we have embarked on training and commitment to a set of principles, the top 10 ways to show respect for people. We developed these 10 through repeated interviews and focus groups and surveys of our staff. What is it that would show respect? What we come to understand is there's lots of subtle disrespect, not the blatant disrespect of throwing or yelling, but really the subtle things that happen every day. And we know we need to work to improve that. We began this education and training and expectations with our executive team. Executives define mandatory, meaning everyone, including the doctors, attended this training and committed to working on improving respect for people. To promote safety in our organization, we also want to recognize people who speak up. So we make an important decision for the Good Catch Awards, those people who speak up and avoid safety concerns. So it's a critical component, part of our system to celebrate and recognize individuals. Systems that we need to support our organization beliefs. Well, how will those systems interact with each other and enable our organization to execute on our mission and vision? Engaging the staff and supporting their connection to the larger organization is a critical component of our leaders' standard work. And you see in this graphic that we have our strategic plan, but we also have 5-year plans, annual goals that come from our 5-year plans. We establish our improvement priorities, our VMPS, Virginia Mason Production System. From that, we also have departmental plans and goals, and from those spring the individual goals. So individual goals in our organization support the department goals, which in turn support the annual goals of the organization. And our staff all have commitments to these. We also have compacts that we have established our expectations of our physicians, our leaders, and our boards. And the aligned expectations help us come back to that on a regular basis and say, ask ourselves, how well are we doing in living up to the behavioral expectations that will help us achieve our vision and mission of patient first. Transparency was another component that I mentioned to you, our beliefs that we must be transparent in all we do. And this is not an easy thing in healthcare, where we often feel that we shouldn't be disclosing issues around our healthcare. But here's an example recently of executives taking this uncomfortable step and offering current and prospective patients and their families access to our provider ratings and comments. They gain additional insight into what other patients' interactions have been like regarding our physicians, and can make informed decisions about choosing a provider that is right for them. Virginia Mason is already a leader in transparency, and we are now bringing this same transparency to our patients' experience with clinic providers. Internally, we use the data and comments from our surveys to help the patient relations and service teams focus on issues of great importance to our patients and families. So how would you respond in your organization to these comments and quotes from her patients? My doctor only works part-time. Sometimes I had to see another doctor when I needed to have help. She always gives me enough time and respect to me as a person. Excellent physician. But we also know that at any time there could be comments up there that are not as comfortable, and we have to be ready for that. But we believe being transparent helps us all be better. So our mistakes and a learning organization was another one of our key beliefs, and that our mistakes are acceptable. And that's, again, in healthcare quite difficult to accept that we can have mistakes and learn from those mistakes. Obviously, we don't want to have harm, but we also think about if we know about those mistakes and there are systems related, that we can begin to work on improving and eliminating those through our mistake proofing processes. It's critical to develop the systems to ensure root causes are identified, and we engage the team to own mistake proofing themselves. So I'm wondering if those of you listening today would file a patient safety alert if it involved an error you made. Our willingness, a culture in which someone would report themselves having made an error is important in moving towards a culture of safety. Our patient safety alert system is where all of our staff, as I mentioned much earlier in the presentation, feels that it's their role to speak up when they say a safe concern or there has been a safety event. So how do we engage all of our staff in learning new tools, new beliefs, and new processes that we can eliminate waste and improve quality and safety and put our patients first? We've invested heavily in our education and training programs. All of our staff at new hire I have a 2-hour orientation to our methodology. We also have general education that all staff are able to engage in. The VMPS leader training is a requirement, and you need to complete that upon hiring into a leadership position or being promoted into a leadership position within an 18-month time period in order to be a leader at Virginia Mason. Our executive level is actually certified in our methodology and leads workshops, primarily our executive sponsor improvement, but knowing the detail level of this methodology really helps you be a better sponsor and to set bolder targets than might otherwise be. We also have a VMPS fellowship, for which is by invitation and considered part of our succession planning processes. So part of standard work for leaders is to engage at the front line, not in the office, and we expect leaders to lead by communicating urgency of change, leading from the Gemba, the place where the work really occurs, not in our offices or conference rooms. We need to establish a shared vision, ensure that people understand how their work aligns with that vision. Make expectations that transparent, engage the team in change, and help and coach them in the skills necessary for PDSA skills. We always say, go see, ask why, and show respect, and then celebrate and recognize the sustainment of change. So growing our leaders, our overall talent strategy is important. You can imagine that as we develop a culture based on those beliefs, that not everyone in our organization when they come is first able to engage in the same way those that have been here for a while. So we see that the development of our leaders internally is an important component of our strategy for ensuring that we achieve our vision and mission. We focus on the executive and leader capabilities, and we are building ready leaders at every level of the organization. So leadership talent approach. Today we review the top 200 leaders in the organization on an 18-month cycle. That includes our directors, our administrative director, and our physicians, our section heads, and as well as our emerging physician leaders and executives. We started that process in 2012 with conversations at the executive positions, and today we're identifying and developing high potential talent throughout the organization. We have some guiding principles to that talent planning and development. One is that talent is owned by the organization. It's an organizational resource, meaning you might be a leader in the financial area, and in the future you might be leading the laboratory. So we see it as talent. Where the talent is needed, we align our leadership. Executive leadership is accountable for developing that talent. Assessment is broad-based and supported with specific behavioral examples, and executive leadership is responsible for Ready Now candidates. The process of the review happens by having a conversation with your reports. As an executive, I would meet with my directors, and we would discuss the talent, the strengths and the opportunities and the aspirations of the individual. The talent review session would occur, and I would present each of my directors, And I would then have feedback from the other executives as to their experiences and ideas of how to continue to help them develop. I would then again meet with my directors with that feedback, and we would monitor and develop. This is just a picture of that as we meet together, all of the executives. There's about 30 of us, half of us physicians and the other half the administrative executives, and we talk together about each of those leaders in the organization. That allows us to calibrate our expectations of each other, as well as understanding whether there are opportunities for growth and development outside our normal accountability areas. We think of our development opportunities not as classroom. Only about 10% of it is related to training or reading or workshops. We really look for experiential-based development for our leaders, assigning them special projects and opportunities throughout the entire organization. As I mentioned earlier, we believe in creating versatile leadership, meaning you may work in a corporate area, a hospital area, or a clinic area. You may move into our Kaizen Promotion Office, which is our improvement office, for a 2 or 3 year assignment, and then be brought out into the organization again in an operational area, but it may not be the area that you were previously in. We found this is a great way to really develop leaders and to have ready candidates for leadership positions as they open up. Of course, our management system and daily management for leaders is part of what we have developed over these past 15 years. And this has been a significant component of the expectations of all leaders. And these are the 6 elements of creating that new culture in a daily management method. Visual controls, daily accountability processes, leader standard work, discipline, root cause analysis, and daily Kaizen. It's the daily Kaizen that really is about engaging all 5,500 staff. So the management system has been key to changing our culture, and it was adopted because of how well it aligned to help us achieve our vision. The patient's always first, focus on the highest quality and safety, engage all employees, strive for the highest satisfaction, and maintain a successful economic enterprise. So I think the key points that I would make about executive leadership or any leadership is that we need to be transparent about what it is today. We need to be bold and humble about what is. We need to have a vision of what we aspire to be, so we need to know where we're heading, and we need to have alignment among all of the leaders towards that aspiration. And then we need to be thoughtful about creating the systems and practices which reinforce that vision and beliefs. And of course, being a learning organization, we won't get it right the first time, but can we pause and reflect and adjust our strategy to achieve what we do aspire to? So now we'll open it up for questions.
Yes, we've received a number of very good questions, and please continue to ask your questions. We'll try to get to as many as possible. Diane, a great question we just received is, how do you break out of an onerous annual planning burden that utilizes considerable resources and doesn't connect our people to our vision?
So my first reaction to any improvement question, and I think this is what the participant is asking, how do we improve our annual planning process? That it's burdensome, that it's probably contains a lot of waste. So we would always take the approach, let's use our methodology. So we would gather the people who are involved in that process, and we would look for the waste, understand current, envision a future process that would eliminate the wasteful activity. So I would use our methodology.
How much time should executive leaders spend on the Gemba, where the work is done, in a typical week or month?
I think if you're talking about Gemba rounding, being out in the Gemba in your own areas, the areas that you have formal accountability for, I would expect that to be on a weekly basis you're out in one of the areas that you have accountability for, such that within a month's time you've rounded in each of those areas. And some folks have quite broad areas of accountability, so I think you have to set up a schedule. I think the important thing is that you're intentional and that you're deliberately getting to each of those areas. But I also think best practice is rounding in areas, as an executive in this organization, the areas that I don't have accountability for, so they begin to see the faces of our executive team. So we have an expectation here that at least once a week I round in an area not my own, so that I can get out and meet with the staff, meet with the patients, and understand the issues that they're facing, and also to recognize the hard work that they're doing every day.
Another question, Diane. How do we handle standard work for leaders and managers, and can you provide an example of standard work for leaders?
Sure. Well, we ask the leaders to generate their own standard work, to be honest with you, because they and only they know most in their work unit, their specific work unit, what is needed on a daily, weekly, monthly, quarterly, annual basis. We do have a requirement that everyone has their checklist and that they've described that. But one of the ways you begin is simply recording, what am I doing every day? And everyone has their own routines. But we do have some general expectations of every leader at Virginia Mason after we've studied this, which is every leader will have a huddle for 5 minutes at the beginning of each of their day to make sure that the staff have what they need to do their work for that day. So we make the requirement that there's a huddle, but how many huddles they have, or how long that huddle is, or what they cover in that huddle is really driven off of the individual leader. That checklist is discussed with their report. So each supervisor would meet with their manager and discuss, this is what I think we need to cover. And then, of course, as I mentioned earlier, this is a learning cycle. So I think I should be doing this on a daily, weekly, monthly basis, but am I doing it? And I'm tracking the things that don't get done, and then I'm finding some countermeasures to not being able to do that. And so that requires, again, that we work with our leader to ensure that we are covering everything that we would expect.
What lean visual management tools have you found most useful for staff and physician engagement?
So production boards, understanding what our daily production is going to be, even that terminology, production, what are we producing every day as a work unit? So being transparent and visual about that, and huddling at that production board each day and understanding what it's going to take to be able to meet demand today is probably one of the more useful tools. I would also say we have a weekly improvement huddle called our People Link, and that's where we convene for 15-20 minutes every week to make sure that we're making progress on our improvement areas for our work unit. So I think both of those have been quite important.
How do you best engage physicians in in consideration of their time constraints and general disconnect from operations?
Well, I think my first reaction to that question is that they are intimately involved in operations. They are the front line in our operations. So if we really want to make real and sustainable change that is helpful to everyone, we have to engage with them. We understand that it's difficult to pull physicians off the line to do this work, but we have found that it's enormously beneficial, not only for commitment to the changes, but understanding how we all play a role in the work that's done and appreciate. We often only know our piece of that work. So although it seems impossible sometimes to take a physician offline for a day or 2 days or even 5 days, we have found them be tremendously helpful. Now, the other strategy, obviously, is what is it that's causing them to be frustrated, and working on those issues and demonstrating the methodology can quickly solve problems they've been struggling with for many years. So, again, it's around change management strategies.
Question we just received: how do you define who your top 200 leaders are?
Well, that's probably based on job classification, to be honest with you. It's really about the executive level, including Dr. Kaplan, who's our chairman and CEO. all the vice presidents, all the chiefs of service, all the section heads, and then the administrative directors is where we began. And then we're moving down. We'll eventually do review all the way to the supervisory level. But we started with the top 200 leaders in this organization.
How do you engage with individuals who are not committed to change or are actively adverse to it?
Well, that's a difficult one, and I think that ultimately as an executive team, when you begin this journey, you realize that not everyone will continue on the journey with you. That said, there are a lot of strategies, change management strategies, to understand what is the resistance that people are expressing. Usually it's around fear that they're not going to be competent any longer if you change the processes, that they don't think they'll be better because many changes in the past, to be honest, we've implemented haven't worked. So there's some legitimate resistance to engaging in yet another management system. Do we really mean it as an executive team? So I would approach it first from helping understand or seeking to understand what the resistance is about. But ultimately knowing that sometimes you have to say goodbye to good people because they aren't interested in changing. So we do need the commitment to improve and agreement with the vision around the patient.
How do you evaluate whether or not someone is well suited to lead internal culture change with Lean?
Well, I think of folks who are most successful leading this kind of work is that they're learners themselves, that they're humble, that they're good facilitators of dialogue and pursuing the vision in interest. So I think primarily when we look at how we recruit people to this organization, we're looking for people who are curious, who are learners, that don't believe they have all the answers. So those are the people that will be most successful.
How do you measure the impact of the leadership training?
That's a great question, and often one asked with any training that is happening. One of the ways that we measure that is demonstrated by actually how they operate on a daily basis. So the training is around some skills, and then we require that they demonstrate those skills. So it's not just classroom training. They really operationally have to demonstrate that. Part of our Gemba rounding is looking for the evidence that they're using the methodology. Are their boards active? Do they look current? Or do they look like that's data from a quarter ago? So part of it is demonstrating that they're actively using the methodology.
How do you balance productivity mandates with the need to engage frontline staff in process improvement?
Well, I think I think the question is asking about productivity, meaning the number of staff that you need to produce the results. And we began this journey quite openly saying to staff that no one would lose their job if they helped us improve. And there was not a promise that we wouldn't have to change due to some service line changes or environmental changes that made us have to make those kind of staff changes. But to engage in improvement, we committed that we would have a job for that individual. That said, we have high attrition in healthcare. So one of the key strategies in this work is to always be managing that attrition, that we shouldn't be replacing staff who leave voluntarily without taking a look at the waste in our processes. So we manage that quite closely here at Virginia Mason. I think we need to be open and honest about productivity, and that we need to have not more and not less of the staff we need to meet our demand on a daily basis.
Diane, this next question is, they want to know, do you have any advice for cutting through red tape and speeding decisions through a cumbersome governance structure?
I think my response to that question is the same as one of the initial questions about the onerous planning process. We would convene a team to work on improvement using our methodology. If we think it's cumbersome and onerous and there's waste in the system, we'd use the methodology.
What financial savings are produced by improvement work?
Well, this may sound a little flip, but it's whatever you decide it is. And setting targets, based on reality in our environment that we're in. I have high confidence, as does the rest of our executive team, that when we set those targets for improvement, including financial, and a good example is in your supply chain, looking for real dollars on the bottom line. I think it's all about commitment, removing barriers, and ensuring that the staff have what's necessary to make those kind of improvements. We are often resistant to make the really hard decisions we have to make, and so again, it's the rigor to the discipline that I see helps us achieve the financial gains we need to see.
So getting back to physicians, a question came in about, in our case, are the physicians employed or independent?
Well, we have both. So at the medical center, in our primary care and our specialty clinics, they're employed. But in our hospital, we also have independent physicians who utilize our hospital. We do require any physician who works at Virginia Mason, either employed or independent, to follow the guidelines of our physician compact and in the commitments of the give and the gets to working in this organization. So it's not limited just to our employed physicians.
How do you engage staff to not complain but offer solutions?
Well, it kind of comes back to what our expectations are as in an organization around our staff. But I find that most of the time the staff are fully able and excited to offer solutions, and it's really the management level, the supervisors, that really have to change their mindset and their beliefs, that it isn't theirs to have to solve problems, but it's to facilitate and coach around PDSA and really create those systems that allow the staff to engage at that level. That takes practice. It's not easy. So the systems and expectations that the organization has of management in our leader standard work is critical.
So Dan, we've received a few questions from individuals who say they're not in leadership positions or senior leadership positions, and one person says they'd like to model leadership behaviors and support continuous improvement. What advice or ideas do you have for them?
Well, I think traditionally in healthcare, leaders are hired for their skills and their knowledge that they bring forward. So I would say in the beginning, a leader can usually lead with their own best practices. So I would become a student of this philosophy, of the management tools. I would gain that skill, excuse me, and begin practicing using this, making things transparent, having production boards, coaching PDSA and engaging in that improvement. So I think as an individual work leader, we can demonstrate that. I think there's limitations to how far you can go. But typically what I see is once you begin to show real improvement and real engagement of staff and better outcomes for internal customers or our direct patient customers, I think the executives start to take notice and wonder what's happening. So I begin with myself, which is true for all transformation. Transformation begins with the individual having a different mindset and a different philosophy and belief. And that is true whether you're working at an organizational level or an individual level.
Next question, how do we track or trend errors and complaints?
Well, most healthcare organizations have some kind of database system. We have our patient safety alert system. It's our incident reporting system, but it's not just that a harm occurred, but it's the potential harm or a safety concern even if no harm has ever occurred. We use all one system. So our safety department is the one who is tracking and trending those patterns of reports. And the complaints come in through our patient relations department, and they're helping us track and trend those complaints as well. We use Press Ganey for our patient satisfaction surveys.
So we have a question here from someone who'd like to understand the structure and the makeup of our Kaizen promotion office.
Sure. Currently, our Kaizen Promotion Office, their role is really to accelerate the adoption of this management method. So their role isn't necessarily to achieve the improvements. It's not a project office, but it's to support and facilitate. So operational leaders are responsible for all improvement. So the Kaizen Promotion has expertise in helping lead those kinds of events and support the daily operations and coaching our leaders in this methodology. They also are responsible for the training that I mentioned earlier in the presentation around VMPS for leaders and our fellowship program. So we have individuals who lead improvement events as well as do the teaching and training. As we've grown, we've also engaged our operational leaders in doing both as well.
So this next question just came in from Rio de Janeiro in Brazil. Thank you, Brazil, who says they're a huge fan, so thank you.
Thank you.
That's nice to hear.
Yeah.
They'd like to know what were some of the challenges Virginia Mason has faced and what strategies were taken.
Well, I think it's interesting because one of the earlier questions is how do you engage physicians, and I think that we made a commitment again very early on that this was not a management system separate from our physicians because of the way in which physicians work in healthcare. So our executive team said from the very beginning that they would be a part of our improvement events. And that was very challenging. It is hard to imagine how do I break away staff for 5 days. So physicians particularly, but even other staff, nurses and techs and those. So we had to consistently help people understand that people do take time away for vacations and they step away for continuing education. So how do we manage that? So I think the strategy really is holding to the principle, holding to the knowledge that when they are involved in these events, that we really can make huge strides in our understanding and our improvement. So I would say breaking away for those intensive improvement activities was a big one. And the other one, of course, is the worry that I'm going to lose my job. And I think our making the bold statement right up front that people would not lose their job. And we did do some retraining. And we did rotate people into the Kaizen Promotion Office early on when we didn't need as many people for certain processes. So I think those are a couple of our strategies.
What would you say or ask of a senior leader who doesn't think they produce anything?
It's harder. The higher you go up in the organization, it is harder to understand what we're producing. I think it's about tracking what you do every day. And what we produce probably has longer lead times, as we say. You know, we're producing budgets. We're producing meetings. We are producing probably meetings is unfortunately a lot of what we're producing. So I think it's really just using your expertise, going out into the Gemba and hearing what managers are producing, and that can lead to discussion about that. So I think it is a challenge, but I think we work together. We often do this learning in collaborative form. We gather up individuals, so a group of executives would meet and talk and work together to understand what we're producing.
Do we have ways for recognizing excellence against incident reporting? Is there a reporting system? What are our methods?
Do we have a reporting system for recognizing excellence? I'm not sure I understand the against the incident reporting, but in terms of best practices rather than just the near misses or reporting when we say the Good Catch Award. We have annual recognition. In fact, one of our outstanding recognition is really our Mary McClinton Award, which is given annually to the team that has done the most in improving quality and safety in the past year. As many of you know, Mary McClinton was a woman who died while in care here by preventable error, and we have recognized and honored her each year in this award, and it's the most prestigious award at Virginia Mason based on our feedback from our staff. Mary McClinton's family comes annually to help us celebrate continuous improvement in quality and safety year on year, and we're quite honored that they do so.
How do you see the relationship between organizational systems and culture?
Well, again, as I said earlier, I think that we have to say what we are today and what we aspire to be. And it's only through our systems, our policies, and our procedures that we can hardwire those behaviors that are going to achieve those better practices. So I rely heavily on understanding what is the system that's either supporting or a barrier to us behaving in a particular way that's going to promote the culture we aspire to. Culture, again, is a word that often is quite ambiguous, but it's really a collection of behaviors, normative behaviors of our executive leaders, and through that, those system practices that we can hardwire those behaviors, and it isn't individual dependent.
How should we approach our first steps towards lean culture, lean healthcare and transformation with an existing chaotic processes and culture?
Well, this may seem simplistic, but you just begin. If we're a learning culture, if we're promoting a learning culture and a learning cycle, we're going to begin by declaring what it is we want to be. We need to have that vision. We need to have a group of individuals committed to learning what we aren't, and then how would we change our behavior, what are the practices that we need to begin, and that we learn from that. So you begin, you reflect, and you adjust, and that's the continuous process. We aren't where we plan to be, even after 15 years. We have to continuously learn.
So this is the last question I have now, but I would encourage, we have a few more minutes if anybody has a last minute question here, so I'll just go through this and some additional information. So Diane, from your perspective, what is the most successful lean philosophy? Interesting question.
Well, I think that it relates to a slide also that I said. I think the lean philosophy is quite published, and I think of it as customer first. For us, it's patient, but it's internal customers as well. So customer first, quality and safety, and a belief in zero defects. It's about full engagement of our staff and a successful economic enterprise as well.
Oh, last minute question coming in here. Trying
All
to
right.
read it. How is Virginia Mason aligning its lean strategy with its patient experience perspective?
Well, when we establish our annual goals each year, the process begins about May, and it involves scanning our environment for all kinds of data that would inform us about the performance level that we currently are, and that includes our patient satisfaction data, our patient experience data that would inform us where are the areas that we need to work on to really improve and close the gap between what we are today and what we would want to be in the future and what our patients and families are telling us. So we do that related to patient satisfaction data. We do that related to environmental concerns, about regulatory concerns, about our own growth and development. So we're scanning the environment, and then from that we develop our annual goals.
So we did have a question come in from Portugal, so thank you for the person typing from Portugal. The question is about physicians, but I think it applies across the board to those who are arguing about whether or not zero defects are possible.
Yeah, that's a great question. It's a hard one because we know the difficulties in healthcare, and we're dealing with human beings. And I think it's really about, will we ever get to zero? Perhaps not. But we have many examples in healthcare where we believed infection rates, for example, ventilator-acquired pneumonia, other kinds of things that we have really made huge inroads into eliminating these defects, as we call them. Now at Virginia Mason, we have a definition about a defect. We know that there are mistakes. We are human, and it's a very human system here in healthcare. So a mistake can happen, but the defect is when it reaches our customer. So there are many strategies around mistake proofing, eliminating defects before they reach our customer or our patient in this case. And so that's our strategy, constantly working towards mistake proofing. And if we have a belief that defects are acceptable, then we have to also accept that that one patient, that family member, that sister or brother or mother, it's acceptable that that one have a defect. And for us, that's not acceptable. So it's an aspirational goal, continuously working towards zero defects.
So we have a few more questions, but it seems we're almost out of time. So we are going to send everyone all of the questions with responses in an email along with the recording. So I do want to thank all of our attendees for participating today. Thank you, Diane. I also just want to share before we close out here, if you'd like to continue educating yourself, learning more, we do have an extensive knowledge base on our website, which includes case studies and articles, a lot of great information. We share a lot of this content, but we also share more than that, experiential information on social media, Twitter, LinkedIn, Facebook, so please follow us there and talk to us if you'd like through social media. You can also learn about our training and services, including workshops, coaching, and organizational transformation services on our website, which is virginiamasoninstitute.org. And you may contact us directly. Please do with any questions or inquiries. The email is info@virginiamasoninstitute.org. As stated earlier, you will receive the recording as well as the Q&A document. And so we really, again, thank you for your participation. We hope you learned something and enjoyed today's session. Thank you.